I would like to talk through the topic that whether there is a role for endoscopic strategies in non-alcoholic steatohepatitis. I'll talk about how duodenum is an endocrine organ. I'll talk about the procedure called duodenal mucosal resurfacing and present you the results of sham-controlled double-blind feasibility study. First of all, there are two lines of evidence which suggest duodenum is a key endocrine organ. First of them comes from bariatric surgical procedures where one sees improvement in glucose level straight after Roux-en-Y gastric bypass well before the weight loss starts, which suggests that there are endocrine functions of the intestine which determines these changes in the blood glucose. Initial thought process was that food being exposed to distal jejunum and ileum early, where the cells are producing anti-diabetogenic signals, might be the reason behind it. But more recently, the thought has moved on to what's called a foregut hypothesis, which highlights that the avoidance of exposure of the duodenum to the food products and the cells producing diabetogenic signals is the reason why we see this early response. If you feed one into the mid-jejunum using a balloon catheter, then insulin sensitivity increases. Second line of evidence comes from what is called adaptive resizing. Intestinal stem cells respond to nutrient cue by breaking away from the homeostasis into hypoplastic mode. And there is duodenal mucosal hyperplasia, and the androcyte mass increases with glycosylated hemoglobin levels. And this hyperplasia is mainly due to glucose-dependent insulotropic peptide expressing K cells. If there is hyperplasia of the duodenum, duodenal mucosal resurfacing approaches to remove this epithelial hyperplasia and resurfacing and rejuvenating epithelium will put the endocrine organ back into its physiological state. The procedure involves a guide wire passed into a distal duodenum and jejunum, and a dual function catheter system is passed over the guide wire alongside the scope, and a balloon inflates, and the needles designed on the outer lining of the balloon inject submucosal saline to lift up the epithelium, and then mucosa is ablated by the hydrothermal balloon. And this cycle is repeated to ablate 10 centimeter of the post-papillary duodenum. In the first sham-controlled double-blind study of the effect of the DMR was investigated in patients who have got suboptimally controlled type 2 diabetes. Overall, there were over 100 patients were involved, and in summary, 24 weeks post-duodenal mucosal resurfacing, HbA1c reduced substantially more than sham group, but this wasn't statistically significant. When analysis was performed with those with the baseline liver fat above the threshold of more than 5% using MR imaging proton density fat fraction, there was a heterogeneity in a non-European group involved in the study. So the data was analyzed separately for European group, where there was significantly higher fall in HbA1c as well as liver fat in association with DMR, while no such benefit were seen in Brazil patients, mainly as the improvement in sham group was much more than expected. Overall, if you take people with HbA1c or a fasting blood glucose more than 10 millimeter, then there was significant reduction in HbA1c in the post-DMR group. There were no adverse events, and procedure-related adverse events were minor, and asymptomatic hypoglycemia was equal in both groups. Now, the procedure, duodenal mucosal resurfacing, has received FDA breakthrough device designation for the group of patients who are treated with insulin and type 2 diabetes. Riveter 2 type 2 DI study is underway to evaluate the effectiveness of duodenal mucosal resurfacing in improving glucose control while reducing or eliminating need of insulin in these patients. Thank you.